myself and Dishi, who is the organizer of this session, and then I'll introduce our speakers and hand over to them. So as I said, my name is Leandra Beuninger. I am personally a PhD student at UCL, also researching methods to mitigate social bias in healthcare and medical AI. And I am also an organizer of the community Data Science for Health Equity, or DISHI as we lovingly call it. And we organized this session, so I'll quickly talk about DISHI. And DISHI is a global community of experts and enthusiasts working at the intersection of data science and health inequalities. And our aim is to ensure that the latest research and innovations in data science and machine learning, as well as AI, improve everyone's health, and especially those in underserved populations. Within DISHI, we have different themes, such as statistical methods, mental health, participatory research, and social justice. And we host many events, such as regular meetups, webinars, journal clubs, and even annual in-person events. And our community is very active on Slack. We have more than 800 people sharing opportunities, resources, discussions, and community support. So if this sounds like something that you might be interested in, then there are a few ways to get involved. The main one being to have a look at our website. You can see the website address on the slide right here, and join our Slack. There is a link to join our Slack on the website, and I'll post it in the chat shortly as well. But now I'm very honored to be part of the program of the International Day of Women in Statistics and Data Science. And we have a cool lineup today for this short session. And it starts with Dr. Eleanor Laws, who is a public health doctor at the University of Birmingham's AI and Digital Health Research and Policy Group. Her work focuses on ensuring that AI technologies in healthcare are safe, effective, and equitable. And she co-led the Standing Together project, which developed recommendations for transparent health data reporting, aiming to reduce inequities in AI health technologies. And today, in her talk, Dr. Laws will discuss how AI can transform healthcare, but also risks worsening inequities, particularly for underrepresented groups. And we're excited to hear from you, Elle. Over to you.
Thanks very much. That's a really nice intro. Thank you. Yes, so I'm Eleanor. Oh, my slides don't seem to be, there we go, just a bit of a delay. So yeah, my name is Dr. Eleanor Laws, and I'm based in the UK, as Leandra said. And I've been working on this project called the Standing Together project for a couple of years now. So I'm going to give a brief overview of what the project was about, and what we've outputted, and how we hope that it'll impact the community and people's health. So I'm sure you're all aware that AI has a lot of potential, but a lot of potential to harm as well. And in a high stakes space like healthcare, that's really quite worrying. And that's kind of where we sit. We are a regulation group where we aim to ensure that AI use in healthcare is safe, effective, and equitable. So it all kind of the journey began with this really large systematic review and meta-analysis that was conducted by some of our team in 2019. And it got a lot of hype because the media kind of recognized that one of the outputs of this study was that AI can match human performance, but perhaps they kind of missed quite a lot of the main findings of this study, in that a lot of the research that was being conducted in the AI space in healthcare wasn't very robust and wasn't really up to the standards that we expect within healthcare research. So a lot of the studies were really poorly validated with external results, but also there was really poor reporting as well, and that's kind of where this whole journey began. We then also conducted a series of systematic reviews looking a little bit deeper into the data that was underpinning these AI technologies used in healthcare. We looked at where the data was coming from, and also at the documentation of the data sets to look for demographic attributes that were being reported, like age, sex and gender, race and ethnicity, etc. And the graph, the map on the left shows where all the data sets derived from across all these different disease areas: COVID-19, heart failure, mammography, skin cancer, ophthalmology. So a huge breadth of different healthcare conditions. Actually, you can see that there are huge parts of the world that are just not represented within the data that we saw was underpinning these AI technologies. And then if you look at the graph on the right, you can see that actually a lot of the demographic attributes that you might think would be quite widely reported and things that you absolutely should include, like age, a lot of the time those weren't even reported or included within the data sets underpinning these AI technologies. And that has serious impacts on people's health, because if we are not training these tools on data that is representative of different populations, the likelihood of those tools performing well for those populations becomes really small. And this phenomenon has been coined, I like a term for it, it's been coined by our group, and that is health data poverty. And it's the inability for individuals, groups, or populations to benefit from data-derived discoveries and innovations due to insufficient data that are representative of them. And if you think that the groups that are most likely to be poorly represented within data are probably the ones that are already experiencing health inequity, if we then don't include them within the development of these tools, there is a risk that we can worsen the situation for them by these innovations. And that's something that we really want to try and prevent. Now, there's a lot of different ways that bias can creep in through the AI development, and we want to just make that clear that this isn't kind of the fix, this isn't the be all and end all, but it's a really big part of the process, and we're really looking here at the data collection aspect of that. And that's why we've developed these recommendations, called the Sounding Together recommendations. We're thinking about the composition of data sets, transparency of data sets, but also how those data sets are being used. Now, this is a really big international effort involving lots and lots of different organisations from across the world. And if you'd like to look a little bit further into the recommendations, you can head to our website, datadiversity.org. But I'm going to describe a little bit about how we kind of wrote these recommendations and also what they include as well. So we started the journey by doing a big scoping review and literature review to build the draft recommendations. We wanted to know what people thought should be included to start with. And we then entered those draft recommendations into a series of voting rounds. So we invited people from all over the world to contribute and decide whether or not they thought recommendations should be included. We ended up including 350 people from 58 different countries across the world. And I'm fully aware that there are really big parts of the world that aren't included on this map. But I think, we really wanted this to be an international effort. We did not want to be UK centric. And okay, whilst we haven't managed to get every single country in the world, I'm really proud of the reach that we managed to get, because actually quite a lot of the continents we did get some great representation from. So very proud of that. So what are the scope of these recommendations? We think they're recommendations for best practice. We recognise that they can be used in every stage of the life cycle, but are probably more useful towards the later stages. They're principle-based, and they're of sufficient detail so that you can actually do something with them, but we also wanted them to remain quite flexible so that you can apply them in whatever setting you are in. And whilst they're intended for the AI machine learning space, we actually recognise as well that they could have relevance to loads of different settings, and wherever you're using data, which is kind of everywhere now, these probably could have relevance. So hopefully could be of use to lots of people in this audience, especially. So here's just a little overview of the recommendations themselves. It's split into two parts. So the first part is recommendations for dataset documentation, and that's very much thinking about the actual data. What has been done to it? Have there been any modifications? Is there anybody missing? What groups are in there? What groups aren't? Have you included patients and the public in the development of that data set? And that's really to encourage people to be transparent about their data, so that if anyone were to go and use that data set, that they'll be well informed about its benefits, but also its limitations as well. And then the second part of the recommendations are more about the use of that data within the development of the AI technology. So what have you identified any groups that are at risk of harm already because of the health condition that you're looking at? And will their output be worsened by this technology? So that's kind of what I was mentioning at the start. But also, are there any groups that you didn't expect that have worse performance because of this technology? And if so, be transparent about it, because if people are then going to procure your tool and use it in their setting, it's kind of essential that they're aware of those limitations of that tool, so they can decide whether or not it's right for their purpose. Now, they're very complex and detailed, and I appreciate that. And I want to flag that we have these recommendations available to download right now on our website, but we also have a publication coming out with much more detail, accompanying explanatory text, so that you can understand how you might interpret some of these different items. And obviously, if you'd like to get in touch with us, we are more than happy to hear from you. We've had some endorsement from lots of different organisations, which we've been really pleased about. We were mentioned within the UK AI Safety Summit last year. We've also been endorsed by UK regulators, regulators in different countries as well, like Australia, and also medical funders and journal editors. And I think that's really interesting, because if they're endorsing it, I hope that people will then be prompted to kind of think about this sort of thing a bit more commonly, and hopefully that will then lead to a bigger culture change where people are being transparent about what they've done and what they've included within their AI technologies. So that's all from me. Just to recognise that this is a really big collaborative effort, and this is the group that kind of also were the workhorse of this big project. So thank you very much to them. And if you'd like to find out more, then please do head to our website. But I'm now going to hand over to I think back to Leandra, who can introduce the next speaker. So thanks very much.
Thank you so much, Elle. That was perfectly on time. If people have questions, please put them in the chat, and we'll have a short Q&A at the end of the session. But now we're just gonna blast on over to Claire. And Claire is Claire Coffey, who is a PhD candidate in health data science at the University of Cambridge. And her research focuses on fairness, inequity in medical AI and predictive healthcare algorithms. And with experience in AI for autonomous vehicles and multiple patents, Claire's work now targets the accuracy and fairness of cardiovascular disease risk prediction models. In her talk, she will explore how widely used clinical models such as Q-risk 2 and 3 often perform poorly for minority and intersectional groups due to biased training data. Claire proposes ethnicity-based recalibration to reduce the disparities, but emphasizes the need for equitable models that address hidden disparities across various population subgroups. And we're keen to hear how she does that.
Thanks, Leandra. Let me just share my screen. Does that look okay?
Yes, perfect.
Perfect. Yeah, thanks very much for that lovely intro. And so, yeah, I'm going to be leading on a bit from what Eleanor's already discussed about different potential sources of bias in the life cycle of some algorithms. In this case, I'm looking at cardiovascular disease risk prediction algorithms, and that's what I'm going to talk about my work on that today, or a little bit of it. Oh, I can... Okay, so yeah, I similarly have some examples of algorithmic bias in medicine and healthcare, and unfortunately it doesn't take very far to find examples of this. And so there's examples from cancer to kidney injury to healthcare prioritization algorithms, dermatology, and of course COVID and inequality. And the more these tools are used, of course, the more important it is that these tools actually are not experiencing these algorithmic bias issues. And so that's what I am looking into. And so one area in which algorithms and predictive models are used is in clinical risk prediction. And what these algorithms do is they work by identifying people who are at high risk of developing a disease before they actually develop that disease. And so one disease that these are used often in is cardiovascular disease. And this is a perfect candidate for these kind of models because it's mostly preventable, but it is also a leading cause of death worldwide. So these algorithms have a very high potential for hopefully preventing some of these deaths. And so these models are used to impact the screening, diagnosis, and also treatment decisions, of course, alongside clinicians. And of course, like in any medical field, these risk prediction algorithms should also be providing equally good predictions for everybody, regardless of any characteristics that they might have. However, as we've seen in some of the headlines there, some existing models in this space or in related spaces actually fail to produce equitable predictions for everybody. And in fact, most of these tools have not really been analysed. And they've certainly not been analysed in a statistical fairness sense, which I'll come on to in a moment. And often they're not looked at across a range of characteristics, especially intersectional characteristics. And so one area that we can use to investigate this is called algorithmic fairness. And this comes from the machine learning literature, and it's a way of quantitatively measuring fairness. And really the goal of algorithmic fairness is to ensure prediction models work optimally for everybody, which is exactly the same goal that we have for the prediction models themselves. So a quick description of how you might calculate some of these algorithmic fairness metrics. And so here I've got a confusion matrix, and we've got on the y-axis the predicted risk, and on the x-axis the observed risk. So you can see whether you can look at whether an algorithm predicts somebody to be a high risk person, and then whether they are actually a high risk person, which we can measure by if they go on to contract a disease, for example. And this can then be used to calculate a lot of different fairness metrics, which I'll go into a little bit in a moment. And yeah, in this case, we really don't want false negatives, because this means that we'd be missing potentially high risk people. And then the others, true positives and true negatives, we definitely want, because it means that we're predicting people correctly. And false positives, we don't want so much, but don't mind too much, because it means that we're predicting people with higher risk than they actually are, but we have a safe and effective treatment. And it means that these people don't go on to develop cardiovascular disease, which is really the goal. But choosing the correct fairness metric, as I mentioned, there are many. It really depends on the context. And here's an example of a fairness metric. So there's one called equal opportunity. And what this would say in this context is that you'd want the same percentage of cardiovascular disease events, for example, heart attacks or stroke, to be predicted for all groups. Do you think this would be fair? Think about it for a second. So in this context, perhaps this is not the most fair definition, as we see very different rates of cardiovascular disease in different groups. For example, men are much more likely to experience heart attacks and strokes than women. But this could be a good definition of fairness elsewhere. So another one is equal accuracy. And in this case, we'd say that we want the total percentage of correct predictions, which can be either that somebody experiences a cardiovascular event or not. And that should be the same for all of the groups. So in this case, this is probably a better definition. But one metric that is used a lot is calibration. And this tends to be used in the development of epidemiological models. And so this is one that I focus on as part of my work. And really what it says is just that there is an equal difference between the predicted and observed outcomes across all risk quantiles for a group. And this means that basically the predicted and observed outcomes are the same for all groups. And so we want to minimize the difference between groups of these. But there's many other fairness metrics, which I won't go into now as there's not really time, but here's an example of some which look at accuracy, differences in false negative rates, etc. And so the research question in this case is how we can evaluate existing clinical cardiovascular disease models for algorithmic fairness. And the procedure for doing this, which can be for any model or risk factor. So you'd pick a model, for example, Q risk, and then you can split a population into groups. This could be characteristics such as sex, ethnicity, deprivation, or any group of interest. And then you would use the model to make predictions for each group, and then look at how the predictions compare to the actual observed outcomes. And you can do this by looking at longitudinal data, which over many years, and see what happens to people. And then you can calculate a variety of algorithmic fairness metrics on this, for example, using the confusion matrix I presented before, looking at the difference between observed and predicted outcomes. And really, this procedure can be transferred to any disease model or risk factor. And so in this research project in particular, we use the UK Biobank data, and this is a longitudinal data set, and it allows us to analyse people over more than 10 years. And we analyse a few different cardiovascular disease prediction tools that are used in the US and the UK. And then we also analyse this over a range of groups, mostly that are protected by law. And so this is age, sex, ethnicity, deprivation, and some intersectional groups such as sex and ethnicity and deprivation and ethnicity. And so back to using calibration then as the fairness metric. So actually what we can also do with calibration is improve fairness by using a technique called recalibration, which adjusts the predictions for a certain group to make sure that the predictions and the observed outcomes align with one another. And so this can then be a fairness improving technique. And this ensures that, as I said, the predictions match the observed outcomes. So now, if this isn't clear, perhaps I'm going to show you some examples of some results that we have. And so if you look at these models out of the box, and so I'm going to show you Q risk here, we see on the x-axis the predicted outcomes across the risk deciles of a population, and then we see the observed outcomes on the y-axis, and this is across the whole of the UK Biobank data. So here we see in the orange circle that the predictions and observed outcomes are not quite aligned. However, the UK Biobank data is different to the data that these models are built on, for example, for the whole UK population. So what you would typically do is recalibrate these models. So we would see predictions and observed events aligned. And so this is a solution that is typically done, and you use the sex and age risk estimates for the population. And then this then in the orange circle, we're looking at specifically the triangles are then basically perfectly aligned. So that looks like the predictions are working extremely well. However, if we then look at this in more nuanced subgroups, which is what I'm interested in this whole analysis really, is that we can see if we look at the white population, these looking at the pink triangles, it's basically perfectly aligned. However, if we look in a South Asian self-reported ethnicity group, we see that actually highlighted by the orange circle, the observed and predicted events do not necessarily line up. And in this case, actually, we're seeing more cardiovascular events than what is being predicted, which is potentially even more of a concern, as it means that we're missing high-risk people in this category. And so then I thought, okay, well, clearly this recalibration procedure is not working for all ethnicity groups. And so what you can then do is look at recalibrating based on ethnicity. And so then highlighted in the orange circle, we see in the crosses, if you recalibrate specifically the model separately for different ethnicity groups, then you see that the predictions and observed outcomes are very well calibrated. And so this is an idea of a way in which people could perhaps be assessing these type of models and then correcting for this potential unfairness. But this needs to also be analysed in bigger data. And so this is just a quick summary of one aspect of this research project. And yeah, about quantifying and improving the fairness of cardiovascular disease risk prediction by assessing the performance in nuanced subgroups. And you can use fairness metrics to do this. And then picking the right metric is important for the context. And although I've presented calibration today, there's lots of different metrics you can use, but you can improve these models, for example, using a nuanced recalibration procedure for separate subgroups. So I'd like to thank you all for listening today. Thanks for Data Science for Health Equity for having me as part of this session. And I've also got thanks to my supervisors for my PhD and my funders from Wellcome, HDR UK and the Turing Institute, and of course Cambridge for hosting me. Thanks, I'll pass it back to Leandra for any questions.
All right, thank you so much, Claire, and well done on time, both of you. So we have a bit of time even for questions. So to all of the audience, you can post your questions in the chat if you have any. And until then, I'll just quickly ask a couple of my own questions. I have a million questions because these things are exactly what I am working on, but I am trying to keep a high level, so it's actually interesting for everyone and not just me. But it was really interesting to see Elle speak more on the data side and Claire speak more on the model side. I think that's a really interesting interplay, and I think it actually shows that the efforts to really improve equity need to have all of these different aspects that we work on separately. Eleanor, do you have one key tip that you would tell people when they ask you in an elevator, oh God, I really am working with health data and I would like to improve it, but I don't know where to start? Do you have something that you say?
Yeah, I think my response would be that this is less about trying to be perfect and trying to reach this perceived idea of what representativeness is, and more about just being open and transparent about what you've got. You know, we are limited by what we can collect. In some places you can't collect ethnicity. It's just not possible. It's illegal to do that. But actually, by being transparent about that and just being honest, then at least people can go forwards and make more of a sound judgment about what they do with that data. So yeah, transparency is the key, not achieving perceived representativeness. That'd be my response.
Right, that's actually super useful. What about you, Claire? Do you have an elevator pitch to people who want to improve their model, maybe for you?
I think well, my idea really is to just look at the performance in lots of different groups, because typically actually that is not done, and people tend to focus on a couple of things like accuracy across the whole population, or perhaps often in subgroups like men and women separately, but not in these more nuanced groups. But also, if often maybe people don't have the data to do that, so that is an acknowledgement. But just have a look and see how the performance might differ. I'd of course say try and use these fairness metrics, but you can just look at accuracy or performance overall in different groups, and that's a start.
That's great. I think that's already really useful. So I think for everyone here, if you are interested in any of these improvements, then maybe just take those by heart and then see how far that gets you. If you are interested in more things, Data Science for Health Equity, I just reshared the website, and please join our Slack. We have loads of these events and really, really brilliant people such as Claire and Eleanor in our community who share their work quite often. And if you want to hear more about them, feel free to reach out either to us, to the organizers of the conference, or to the speakers themselves. But with that, thank you very much for joining. Thank you for giving us your time and listening to us. And thank you again to the speakers. You were wonderful and perfect. Thank you so much.